Welcome to Brain Wellness, the podcast. I'm your host, Mandy NP. Each episode will bring you a new topic or interview related to brain health and wellness as part of my mission to help you on the path to a healthier, happier brain. So let's get started. Hello, everyone, and welcome back to another episode of Brain Wellness, the podcast. My guests today are Andrea Zimmerman and Ivy Emery. Andrea and Ivy are board-certified women's health nurse practitioners and co-owners of Harmoni Wellness. They have served in OBGYN for over 20 years combined. While working in their OBGYN field, they identified a gap in care around perimenopause, menopause, pelvic floor and vaginal and sexual health. They started their own practice last April to address not only these gaps in care, but to change the manner in which the care is delivered. They recognize that the key elements to providing care for women are, number one, taking time to listen, two, asking questions about sexuality, vaginal, and mental health that are often omitted in standardized care. Number three, educating clients and offering safe, evidence-based options so women can choose the care plan that's right for them, and following up with clients to ensure questions are answered and therapies are adjusted if needed. So excited to have you guys here today, and we will talk about how this is all related to brains as we go along. But thank you so much for being here today.
Thank you so much for having us. We're pleased to be here. Thank you.
Of course. So my first question always to everybody is tell me a little bit about how you guys got to where you are now. What got you into, why'd you start Harmoni Wellness? We got a little bit of that of your in your bio, but then we'll kind of talk about how that relates to why you're here on the podcast with me talking about brain health.
Yeah, well, I was working in OBGYN for a long time. It was really rewarding work. For me, I always was working at finding a gap in care. Caring for pregnant women and pregnancy is really rewarding, but that kind of chronic, underserved conditions that are part of women's health really excited me because I knew how it impacted daily living and then ultimately long-term health and their mental health. So when I decided to become a nurse practitioner, I didn't pursue so much the midwifery piece, which was the group I was working with, but more thinking about the gynecologic piece. So as things were unfolding and we're learning more and more about, well, we were learning not very much about menopause and specifically perimenopause. But being in the clinic and having the experience where when you're doing an intake and missing questions where people aren't really they're thinking that maybe leaking while they sneeze is normal and it's getting worse, but they're not going to report it unless you ask specific questions. So that was really exciting to me. And then when I met Andrea, right away, we just hit it off. This is the kind of patient care I want to give, and it's different from what we've experienced in the past. And so we became very, very good friends right away.
Agree to all of that. Taking care of patients in a daily setting, even just doing a physical for a woman anywhere from 45 to 65 years of age, it became frustrating for me and kind of a challenge when I realized if I asked a woman if she was having difficulty controlling her bladder, if she was having sexual pain, if she would answer yes, I really had a very limited amount of therapies available to her. And the more I applied those therapies to patients, it became clear that those were not adequate to the task. Many of my patients were not satisfied with those therapies, and yet I didn't want them to always become a surgical patient. So I was trying to find something in between to treat bladder incontinence, urge incontinence, without having patients be saddled with medication for life or a big surgery. And also women would present to me, they are not shy about asking for help when they're having hot flashes. When they're miserable, they're not sleeping, their libido is missing and they don't know where it went. They cannot find it. They are asking for help. And there was really a limited amount of resources for me to give to them that I felt comfortable and safe giving to the patient. And so it really did drive me to want better for my patients and start really digging for more evidence-based therapies. And so it's all come together at Harmoni Wellness. This is the gap in care that we recognized in our traditional practice. we want to do things differently. We want to be able to address these issues and give women better quality of life in the moment, but also give them therapies that we think are healthy and preventative for their health, for their good health as they're aging also.
So how is Harmony different from a typical women's health practice that you would consider going to?
I'm glad that you asked that question. There's a lot of differences we think. The exciting thing about women's health right now is that it's really being recognized as a full body experience. And not only is it treating, as Andrea said, symptoms in the moment that impact daily living, but even those symptoms might impact long-term health. When people aren't sleeping or they're having joint pain and muscle aches, they might not be doing the activities that keep them healthy. And so subsequently hypertension or some sort of condition might happen. So it's the symptom control, but looking at the vitality and looking at all how hormone fluctuations and decreasing hormones affect all the cells in our body. And they're finding more and more receptors in all the tissues and organs in our body. So it's really exciting. And I think that our approach, looking at the whole person, is really different than perhaps what we see given in the care, where it's been so specialized into just OBGYN and talking about, your period and the ovaries.
Reproductive health, and that's it.
So we're different in that way, where we're recognizing and taking in account how it's affecting cholesterol, hemoglobin A1C, it's metabolic, it's mental health, the cognitive function. So that's one approach where I think that we're different. But I would also say our practice is different because we built a model where we have time to listen and we have more time to follow up. And part of that is the time dedicated, but then also the approach to insurance. We absolutely help people get reimbursed as much as they would at any other clinic, but we're also trying to be careful about being beholden to what we can talk about in the moment. If you're coming in for menopause and hot flashes, but we're going to talk about mental health, it changes the appointment when you have insurance sort of binding you to that. And so, and limiting the amount of time you're spending with a client. So we approach that differently, and we're supportive of people having their insurance cover them, but we're also not beholden to other models of care that are more restrictive.
Nice. So is that cognitive piece why I invited you to come on to the show? Because you guys hosted a film viewing of the M Factor. And can you guys give a quick nutshell of what that M Factor film was all about for anybody who hasn't seen or heard about it? Because I was blown away when I watched it. It was so cool. Yeah.
I share that with you. We were blown away when we first saw that movie. And the movie is a documentary. It's the first of its kind. It was just released this year. And it's highlighting the current research from contemporary providers in the medical field all over the United States. And instead of just focusing on OBGYN and how reproductive health is impacted by menopause, it's speaking with researchers and providers about how cognitive health, musculoskeletal health, genitourinary health, sexual health, dentists, dental care, oral health. It's highlighting that menopause is a full body experience. It's not just your ovaries and your uterus that's going through menopause. It's more than hot flashes. It's affecting almost every single tissue in your body. And there really hasn't been adequate research to investigate the long-term consequences of hormone deprivation in female tissue as we age. And so it's really exciting to hear the women who are doing the research in this moment with women that are our age and older in this moment, talking about how does menopause affect your whole entire body, and what are the things that we can do to keep women healthy for all of their days. We are all living longer as a generation than the previous, but that doesn't really benefit us if we're frail and infirm and cannot be independent. So the goal is to capture and maintain that vitality for as many years as we can. And we think that supporting hormones moving forward from perimenopause forward might be the key to maintaining full body function.
I think
Mhm.
too, the documentary highlighted some other cultural views of menopause and challenged culturally how we view menopause. There's some of the history of how did we get to where we are? Why are we in this predicament? What do we need to go forward regarding research? There was some focus on historic medical trauma and just sort of calling out some of that history and why there might be some mistrust with some groups. It really did identify that some groups are at higher risk for worse symptoms, therefore worse outcomes for long-term health or increased disease risk. And then it's shocking to see the statistics when they talk about how many women will go into menopause every year and how many women are well, one of the statistics was 2/3 of Alzheimer's patients are women. So why? We need to know why this is happening. And if there is something that we can do, because we are basically in a public health crisis when you have all of these systems that are shutting down and trying to see all of these different specialists, and it's difficult to get in. So if we can get to a root cause and we can mitigate this disease risk for so many different things by getting to root cause, can we actually get to a better place nationally?
Yeah. And I love that idea of that root cause. That's something that I always have kind of rooted for in my own practice was trying to find the why. Why are my patients sick? Why do they have diabetes? Why do they have Alzheimer's? Why do they have migraines all the time? And a lot of that can be hormonal, but how do we get to that root cause from your perspectives? How do you tease that out?
Mhm. Yeah, it's so true. It's difficult. It's sometimes difficult to know because there are 34 symptoms of
Mhm.
menopause and counting. They're adding more, which means there's over 100 combinations. And so everybody's menopause is different. So it really is taking a lot of time for the clinician to understand what are they hearing. Could X, Y, and Z be related to decreasing hormones? And two things can be true at once. You can actually have a condition and have decreasing hormones. So we really can't see the forest through the trees sometimes unless we're treating for the hormone imbalance and seeing what is resolving and then going from there. So I think that that's pretty much the approach, is like understanding what you're hearing, following up, are things improving? It's a red flag in the back of our heads when someone has chronic migraines or migraines. That's not a contraindication for menopause therapy, but it is for birth control, migraine with aura, but it's not for MHT. But we can't just say, oh, cool, yeah, it's menopause. Here's the magic bullet. You're fine. So following up and understanding, do you have improvement? And then if you don't, then we need to collaborate or be supportive of other therapies that are or that specialty.
Mhm. Yeah, because I remember the one of the questions I posed to you guys the night of the film was TBI recovery. So that's my big thing is recovering from that TBI. I have other people that I have unfortunately become really close friends with that are in the same kind of age category. And how do you tease out the cognitive effects from a TBI from uh, menopause, perimenopause type of things? And I love that you use that line that two things can be true at the same time because it very much can in medicine. We're always looking for that easiest answer that can solve everything with one answer, but you can't always have that. And when you have both of those things happening at the same time, it is very difficult to figure out, well, which one are we dealing with more than the other?
Well, I would add to that that usually if I'm meeting a client or if I see a patient, she's seeing me for a physical, when you've been alive on the earth for 40 or 50 or 60 years, you've had a lot of time to build up any of a number of injuries, surgeries, complications, family history that now is becoming evident in your own day-to-day health. So it's almost never one thing. And I tell patients that women's health is almost never one thing. If you come in and tell me you have pelvic pain, it's a full workup. It's not just one thing. We aren't that cut and dry. And certainly by the time you're midlife, there's always something going on. So it's important when women are seeing someone to investigate the root cause of sleeplessness, muscle pain, forgetfulness, that you're not just set in your ways and thinking it can only be this one thing that I like to treat. You really need to think globally about the patient's health. And even if I can't treat all of her issues, it's really important, as a primary care provider to identify, I think it could be these other things too, potentially. We need to rule out or do the workup. The treatment that I provide here at Harmony is kind of in one direction, but I will absolutely refer you to have these other things investigated that I can identify in lab work or based on your history and what you're telling me. Let's have another provider look into these things for you too, because it doesn't serve you if I only pretend that hormones are the only thing that could be changing in your body or that need to be addressed.
We spend a lot of time educating our clients. That is probably the most valuable thing we do above medication and validating, educating. So they are empowered to understand that they're on a journey and decreasing hormones will happen to 100% of us. It is just a fact. And whether or not they choose to do a hormone therapy or not, that is absolutely up to them. And they get to choose that based on all of the information. But they also are knowledgeable that, if they're coming and they're asking for increasing hormones because maybe something isn't, we've had some people try to, transfer their care to us for hormones and they're already on hormones, and we do a workup and there's a thyroid issue, and adjusting the, I don't want to say I'll say MHT because we've been saying the sex hormones, but that's really a misnomer. So the menopause hormones, we're not going to address this thyroid dysfunction, and that is only going to get worse. So we really need to loop in and collaborate with other practitioners that are knowledgeable, that can support. We can all be supportive and puzzle pieces together to try to get to that optimal health.
So then it's a part of knowing that you're part of the team and you're not the MVP, that you're the only person on that team. It's being a part of that team, because we kind of were talking before we hit record about being in silos. And I've had this conversation with other practitioners as well, as we can't be stuck in our silos of specialty anymore. We have to know when to loop in those other people.
That's absolutely right.
Yeah, 100%. And it's tricky because as women are aging, they have different needs. And, the care of a 70-year-old woman is not the care of a 50-year-old woman. She's in a different stage of life. And so we're continuing to make connections in the community with providers that understand the developmental changes of aging. We're all comfortable talking about little kids with their developmental stages, but we need to start wrapping our minds around developmental stages and adult aging too, and that their needs are different and the way that you support them is different. And Ivy and I have spent quite a bit of time kind of vetting different providers in the community that have demonstrated to us they understand what these physiological changes are and how to support patients appropriately. We actually list them on our resources page on the website. So, and we tell patients, go look at who we have, decided that we take advice from, that we read their research. You can find it on our website. You can share it. You can read it at your leisure, but there are local providers as well that we've identified that we think are valuable resources for patients that do things that we can't.
That's awesome. Yeah. It's being able to have those people that you can refer to and that you trust that they're going to get the information that's going to be most beneficial for your patient. Because we're all in it for the patients. That's our ultimate goal. They are the true MVP. I had a gal on my show a while ago from Canada, Margaret Wallace Duffy, which you guys should follow her at some point too, because she's all about preventive health. And her big thing is having people be the CEO of their own healthcare. So
Right.
trying to put the patient in that seat and really realizing that everybody is around them and we are all on that team to help them. I love that you guys have done that vetting process to find those people to reach out to.
Yes, and we've also changed our education. We do a Q&A at the movie. We've done it 3 times. We're going to do it again because we just get really good feedback, and it's such an educational. People are excited, and it's fun and educational. But the misinformation that's really out there, and the way that people are asking for help and then they're being responded to by certain clinicians. And there's definitely a lot of really great clinicians out there, but really encouraging people to understand that the clinician's job is to educate and offer options, and they can make recommendations, definitely, but they're not making a decision for you, and they're not shutting down a conversation because we're not talking about it anymore. So, even if it's referring to someone else, I hear you, and I don't know about the journey that you're on regarding hormones, or that you want to explore that option. And I hear that. So let's refer you to someone who does. But we're getting reports that conversations are being shut down. So the advocating for yourself and reminding people that we're actually serving them.
Mhm.
It's service.
Mhm.
So did we earn our tip?
Well, yeah, like instead of just, I mean, the model of care really needs to come around.
Yeah.
You don't just tell a patient what to do. I, I'm not in charge of what you do with your body. My job is to give you all of the resources that I can. And then you can feel like you're making a decision for your body. The patient's the one that pays the consequences for whatever it is they do with their body. They need to feel like they're in control of what happens next.
Mhm.
And willing to assume the complications that we talk about, when you give informed consent about all of the treatment options. That's really the change. It takes a lot of time to
Mhm.
sit down and parse through the differences. What are the nuances? What's going to happen to me and how soon?
And
It
why do
takes
we
time.
recommend something
Mhm.
like bringing them on that journey, bringing them inside your head? This is why I would recommend this, and based on what you've told me, or based on what I know on the evidence. And what do you think about that?
Mhm.
And
Mhm.
giving patients, when we sit down in the office, we show them the resources. Hi, I recommend that you check this out. I recommend you spend some time getting familiar with the information this author is providing us, because it's going to make a difference in how you make your choices now and in the future. I think it's really good information for you to base some of your choices on. It's good factual information. And then you can make whatever your choice is, and I'll support you. Instead of just blindly leading a patient into the future and saying this is what you should do. Like, I want them to feel like they know what they want to do.
Yeah.
Mhm.
Yeah.
And
Mhm.
mhm.
I had a similar conversation with a colleague recently too about just making sure that when you give informed information, think of it as informed consent for not just procedures, but any treatment options. So in order to make a decision, the patient does need all of the information. They need all of their options. They need to know the consequences of doing those options, and they need to know the consequences if they choose not to do something, so that they can make that informed decision and that ultimate informed consent.
Mhm. That's right. Agreed. It's really become a big pillar. It was more vague, but a part of our model, but it's come so to the front of what we do, and we recognize that we do, but then also in our speaking events to intentionally carve out some time to talk about advocating for your care.
Yeah.
Mhm.
Yeah. So since education is a big part of that, are there like a few things you guys can kind of touch on, some things that you find yourself educating people on a regular basis, some of the more common things?
Absolutely. I mean, the first thing that we always start with is terminology, because people call everything menopause, and then we automatically think, well, that's not me. That's 70-year-old people. Like, it's really confusing. So we always start with terminology, and we've actually changed the way that we speak about menopause care to always make sure that we're including perimenopause first, because we know that menopause just is viewed a certain way and might shut down a conversation, or I just didn't hear you past menopause. So we say perimenopause and menopause. I think it's a big mouthful, but that's how we present it. But yeah, we always start with the terminology. Perimenopause, average age is 35 to 45 years old, which is really shocking to people. And what does perimenopause mean? It's when the symptoms start, when we start to have changes in our more predictable, gradual cycles that aren't always for everybody, but it's marking the change, and that's when we're starting to see symptoms. And it can last 7 to 12 years. So average age of menopause is 51. And that is one day in your life, even though we call everything menopause, it's one day, 12 months without a period. That's menopause. And then everything after that is postmenopause, which doesn't mean you're done with the journey. It just means that you're done with your periods, we hope. So most people do report that they have symptoms beyond menopause, and it's a shocking number, up into 70 percentile, that people are having symptoms. They might become more mild because the fluctuations in hormones aren't as severe, so they might become more mild. But when they know about all 34 symptoms, they're like, oh yeah, that's me. We do talk about the symptoms themselves, because it helps people get a feel of where they're at on their journey, or to understand it's not just the Fab Five: hot flashes, low libido, insomnia, brain fog, fatigue. It's 34 different symptoms. So when it's pretty interesting to see people go through the list, because they'll say, oh, that for years, that for years, that for years, by the time they come to us. And then also talking about not just the symptom control or the symptom management, but then also how it impacts long-term vitality and independence, and decreasing risk for cardiovascular disease, metabolic conditions, musculoskeletal syndrome of menopause, osteoporosis, the cognitive disorders. There is a link in this. This is what we're talking about. Other than neurologic symptoms that are like tingling extremities and skin crawling sensations, there's also links to dementia and Alzheimer's with decreasing hormones. There's also the genital urinary syndrome of menopause. So bladders that won't behave and they get worse, vaginal dryness, pain with intercourse, and then mental health. So that's where we start. And then
that's where we start. One of the things that it's important for me to talk to patients about, and then they, when we talk through it, they go, oh, okay, is that the symptoms that you're feeling with menopause today probably are going to be very different in 6 months, and probably are going to be different in a year and 2 years. And I remind them, we can give you therapy for the symptoms that you're having right now. Your body is manufacturing whatever amount of hormone from what's left coming from your ovaries at this time. That amount of hormone that your ovaries are giving you naturally is going to change and diminish over time. Your body is continuing to evolve over time. And so we may feel like we got everything taken care of, and then you're going to feel differently as your body continues to change. So it's my expectation that you come back and say, hey, something else is happening. And that is not an indication that we're doing anything wrong or that your body is in danger. It means that you're continuing down into this menopause journey and through, and that we expect to toggle your hormone therapy in particular to keep up with you. But these 34 symptoms, they don't all just show up on day one in the same strength. They pop up whenever they like. Sometimes they're really bothersome. Sometimes it's really mild, and then something else pops up. This is the beauty of menopause, right? Like, it's always changing. So I like to counsel patients, and they're surprised to think, oh, I can't just treat it once and it's done. No, this is ongoing. And then they feel comforted, like, oh, okay, I get it. And I tell them, you get to be in control of how we use your medication. Like, it's up to you what you want to do as things change in time. And then they're comforted by that too. It's brand new information that they might get to drive the bus a little bit, but it also makes them feel really good. They get to be in control of what's happening.
Mm-hmm.
I think too, validating their experience, where they haven't really, they finally sort of have the words after we're talking to them, they have the words to describe how they've been feeling. And they are relieved, when we do the education piece and, you know, and like Andrea said, we need to toggle medications to individualize this, and we're ready for that. And we know what's going to happen. And that doesn't mean there's something wrong with you. And women sometimes become tearful because they feel that they were sure something was wrong with them as an individual, and they were falling apart. They couldn't figure out, they just didn't feel good in their skin, or they don't feel like themselves, and they just couldn't verbalize what it was. So it can be really refreshing and validating. And that's a huge, I think, another big difference about our practice is that we're always keeping mental health at the very, very front of everything that we do. How do they feel about this? How have they been feeling? How are they going to feel about therapy? Are they going to accept that it's a journey and those are going to be changes that need to be made along the way, and that that's expected, and that they're not going to feel worse emotionally because it didn't work right away, that kind of thing. So mental health is very important.
Yeah. And again, as we were kind of talking before we hit record, there's a huge connection between our neurotransmitters and how our body responds to that. So that our serotonin, our dopamine, all of those things are affected by those hormones that are changing during perimenopause. So it's definitely to be expected. And I don't think people realize that those connections are there. Um, my family, we didn't talk about hormone changes. So I'm the youngest of five girls. You would have thought we would have had some conversations, but no, there were no conversations because in my mom's family, that was not something that we did. We didn't talk about the changes in women's bodies. So she even complained that her mother never told her what to expect during menopause. So when it hit, it's like wham, it's like hitting a brick wall. And so being the youngest of five girls, again, none of us really knew what to expect. So we have these whole generations of people who haven't been talking about it because they were taught that we don't talk about those things.
Mhm.
We were
So
also taught that some of those things are just normal.
yeah,
It's just normal. And it is. It essentially is normal. There's nothing wrong with anybody when we're going through this. We just don't have to live with it.
yeah,
And now we know how it impacts long-term life negatively. So if we can get in and do some preventative care, and not only, I mean, we're almost putting the prevention ahead of the symptoms for Andrea and I, because we just are like so focused on this 75-year-old. You know, she might be 40 sitting in front of me, but I'm looking at her like she's 75 years old, and she is just asking to be the most vital and feel well and do the things that she can do independently to the end of her days. And we're like, I want to jump in at any point and get you there. So it's all normal, but we don't have to live this way. And we have the opportunity and more research than ever, and more of these researchers talking to each other to get us to a better optimal health, instead of just saying, it's just normal. We just fall apart. It's fine.
yeah, yeah. I think the last kind of big thing that I wanted to ask you guys about to kind of touch on from that film was about the research that we've identified that actually wasn't true about some of the hormone replacements.
Mhm.
So I think a lot of people are still fearful of it because of the old knowledge of the research. Can you guys touch on that briefly here?
Well, the study that you're talking about is the Women's Health Initiative, and it was a study that was stopped prematurely in the early 2000s because the researchers felt that women were at higher risk to continue in the study taking medications than continue on with the study. So it's the largest study of its kind, and what the community says is there will never be another study like it because it was so incredibly expensive. Women are difficult to study because of our hormone fluctuations. We're unpredictable, so you can't standardize what every woman's experience is that's a research subject. So it's difficult to do this kind of research in the first place. Essentially, this was a study that was trying to look at cardiovascular health for menopausal women on hormone replacement therapy.
Mm-hmm.
And at the time, the medications were synthetic hormones, ethinyl estradiol and metroxyprogesterone. So estrogen, progesterone products used for hormone replacement therapy. And the women that were included in the study all had to be menopausal and not have any idea whether they were taking HRT or not. So they were all postmenopausal because they didn't want to have anybody know what they were taking, have anyone bleed. So they did find that there was an increased risk in cardiovascular event, and so they stopped the study. They thought that breast cancer was happening, and so they stopped the study. And retrospectively, what we find when we look back at the data is that the population that they had chosen was an inappropriate sample of women to use. They were all too far into menopause to be able to appreciate any of the prevention or safety profile from menopause hormone therapy. Also, many of the clients that they chose already had heart disease because of their age. Many of them were smokers, and we know that that is not a really healthy population to start introducing hormones into their system because it can cause problems. So the takeaway from that study when it was halted was, if you take menopause hormone therapy, it's going to kill you. And so every woman in the country and their providers immediately stopped prescribing hormones. Women stopped taking their hormones because they didn't want to have breast cancer or a heart attack or stroke. And it took a couple decades for researchers to kind of revisit the data, really comb through it and pick out what was valuable information instead of just frightening information, like what's actionable. And of course, in that 20 years, pharmaceutical products have changed and have become more sophisticated. And the menopause hormone medication that we use now is a more sophisticated natural product. It's not natural in that it's human. It's natural in that it's made in a factory, but it's synthesized to be as similar to what the hormones, the molecular structure, to what our bodies make as possible. So it's a better quality product for women who are choosing to use menopause hormone therapy now. So that's kind of why everyone was so frightened for it for so long. There were a couple generations of women that could not have hormone therapy. And so these are the women that are baby boomers now that are really struggling with muscle pain, osteoporosis, dementia, Alzheimer's, bone fractures, falls,
incontinence.
I was going to say vaginal problems, bladder problems, the incontinence industry, like the paper product industry to support elderly women in paper products it's insane. You can go down any diaper aisle you want. There are more adult products than there are baby products. And that is a result of not having hormones in the tissues of the bladder and the vagina. So anyway, that's sort of the beginning of how this data was blast into the public as being very, very dangerous before the researchers and the providers really had a chance to comb through the data and find what really happened here. And everyone was scared off of using MHT because of the headlines, and it just sort of sat that way for 20 years.
That's a really great summary of what we've been through in that and the elements of the study and the fallout. I would also add about the breast cancer piece. So the findings were from the two groups that the MHT group, there was a small increase of breast cancer occurrence. We know that women who are around 65 years old and as they're aging are at a natural risk of all-cause mortality, but breast cancer is a natural type of occurrence that can happen as we age. The average age of, was it 65 for the average age? But women who were in the study were up to 75 years old. So the cohort was kind of ripe for some of that to occur. And the findings were so small. They were actually, when they crunched all the numbers and the statistics, they weren't significant findings, which was pointed out over and over again. But it was like, well, it's significant enough that we are going to shut it down. And granted, having breast cancer is awful. Going through it, we definitely want to keep people safe, but not really taking the time to understand where are these numbers coming from? And also they think now, and there's more research being done about this, that the medroxyprogesterone might have been the culprit. So estrogen has really gotten in trouble for all of this, and it actually might not have even been that product. We don't use medroxyprogesterone in menopause therapy. That's not really what the standard recommendation is anymore. So that medication has been phased out of that. But that was a big, scary announcement, because that's what came out is MHT causes breast cancer. And then it was all over the media, and it's a soundbite that's easy to understand. And it really did impact decades
Millions and millions of women.
and not only for treatment, but it did actually impact the learning that we have in our medical programs.
Mm-hmm. Yeah, I would have thought that as women's health practitioners, you guys would have known so much more about this than I did coming out of my family nurse practitioner program. But I think we probably learned very similar, minuscule amount of information about menopause.
Yeah, agreed. I mean, and they're very open about that in the documentary, about how did we get to where we are and what kind of learning in the OBGYN or women's health programs, what kind of continuing education is required or recommended for us to maintain our licenses and certifications. So I hope it's going to change. I hope it becomes its own specialty, and that it becomes its own, because you kind of need to dedicate your time to learning what the Menopause Society says, which is our governing organization. For those who don't know, it's sort of, I say governing, but they crunch the numbers, the research, they put out the recommendations, the guidelines. And so, knowing what they say, and then knowing what all the new research is, because that new research on average takes 5 to 7 years to become implemented into guidelines and standards of care. So knowing what the new research is, and then what your client in front of you is going through, and addressing that as an individual. So bringing them into that decision making and understanding what both groups are saying.
Yeah.
So it is really, you need to dedicate a lot of time outside of traditional medical learning to become an even adequate menopause provider.
Constant learning process. I mean, it is exciting because there is a lot of research all of a sudden it's being dedicated to menopausal women, which is brand new. There really isn't very much money available for menopausal women's research. So the scientists and the physicians that are out there really, advocating for, we need the research. We really can't treat these women unless we have the research. They're fighting. They're really warriors for our benefits. But it's going to take time to get the research published, because it's not like there's all this money in the world that's available to do the research. So it's really valuable. We're reading everything we can get our hands on, but it's just not as plentiful as other types of research that have more dollars dedicated to that field.
Yeah, it's really hard to provide evidence-based practice when it's hard to get the evidence into published form. Yeah.
Yes.
Yeah.
So the neuroscientist, Dr. Mosconi, Dr. Lisa Mosconi, so she's been researching the effect of hormones on the brain, even how the brain chemistry changes, how we process glucose, and different parts of the brain and how it responds, but then also it shrinks. So why are women's brains shrinking? Which isn't new information, but it was new information that this might be some component of that. She was just at the White House with Maria Shriver, because they have been partnering to explore more about Alzheimer's prevention. And they were at the White House, I think it was mid-December, and she presented to President Biden and Dr. Biden and a whole group of people. And at the end, she said, "We owe women centuries of research." And it gives me goosebumps every time I repeat it, but I tell my clients that, right? Goosies. I tell my clients that because they want to know, why don't I have a lab to understand where I'm at in my journey? And I tell them why it doesn't make sense. And I also tell them, we also haven't had research dedicated to this. So it's not that we're not keeping anything from you. We're trying to advise you that this is not going to be good information. And there's really not a clear picture unless it is only really one scenario that it's a clear picture. So yes, you had the same reaction that I did when she said it. So yeah.
Mhm. Yeah, there's so much room for research on the women's front in pretty much any diagnosis we have. I will tell you guys, I just was talking to my oldest son who is in his doctoral program, and he's jumping on the research to look at different respiratory illnesses with women because all the research has been done in males. And
Right.
I'm excited to see these younger generations interested in doing the research. He's like, it's wide open, Mom. Nobody's done the research. I'm like, have at it, take it on, please,
Yeah.
because we
Jump
need all this
in.
done. So for any potential doctoral students that are listening to this,
Oh, can I
please
make a
take up the
plug for
research.
perimenopause?
Yeah.
Because one of the brilliant doctors that we follow, they just had they posted something saying, I asked for research about perimenopause, and the response was, we don't have any. And she said zero, and they said zero.
I was talking with a pulmonologist and sleep
Mm,
medicine specialist just yesterday. She was asking me for articles
Yeah.
about sleep studies and pulmonology for menopausal women. And I thought, you're the one who knows everything about pulmonology. I don't know very much about pulmonology and sleep medicine. And I mean, you really have to dig. There just is this paucity of anyone having spent any time researching women's experience with aging.
Yeah.
Um, and so the good news is there are enough providers out there right now that are wondering what is the best way to treat this female
Mhm.
patient of mine.
Mhm.
And they're, shaking the tree and asking someone to go
Mhm.
find out updated answers.
Mhm.
But it is going to take a while until
yeah.
we have
Yeah.
results. But the process is starting, right? The
Yeah.
process is starting. Our generation um is not feeling real comfortable with, I don't know, just try it. Yeah.
Mhm. Yeah.
So it's going to be different in 10 years. We're going to have a whole
Yeah.
lot more research then, which is good. The wheels are turning.
Yeah. Yep. Practice always changes. That's why it's called practice, right?
Mhm.
We keep learning, we learn new things, we implement it, and we try it, we see if it works, and we keep going. So, yeah. So, for the sake of time, do you guys have any events or projects that you want to share with our listeners?
Yes.
Mhm. Mhm.
I'm like going through the Rolodex of on our page we post when we are guests on podcasts. And so we did just do a podcast with a nutritionist regarding GLP-1 medications, but we're going to visit her again, and we're going to talk about menopause and nutrition and metabolic syndrome. And we are having our anniversary event. So that is going to be at Rock Elm on April 11th, the Rock Elm in Plymouth on April 11th, and we're going to go live on our Eventbrite, and it'll be posted on our events page as well, but we'll post that soon. But it's going to be the Hot Flash Bash, and it's a chance for women to come together and just celebrate where they're at. So it's literally just supportive, people having fun. We are going to have a chance to do some Q&As with people can submit questions anonymously, and we'll stop the amazing music. We're going to do the hits from the 80s and 90s, all the menopausal music, and we're going to have a lot of fun. But we will also have some education and some other vendors, and we just want women to have a space where they are appreciated, and it's all acknowledged. We're doing this journey together. So let's talk about it. Let's commiserate. Let's also celebrate.
We should celebrate it. We get all excited when we go through these other hormonal changes in life, puberty, pregnancy, and then it's like radio silence with menopause. Nobody
Yeah.
wants to celebrate it, and we should. It's this
Mhm.
big change, but there's so many wonderful things to look forward to in this stage of life. And we should feel empowered by it, but also it's fun to take a moment and just, be a little silly, be a little excited about it. Well, yes.
Mhm.
I think it's important to understand that perimenopause and menopause can be our friend. If we're not meeting the needs of the tissues, I mean, our perimenopause and menopause might become a little bit more like a toddler and demand our attention and flare up in certain symptoms. But when we are feeling well, when we are feeling our best, we're in a space where we're headed places with our children and our families and our careers. And there's a lot of value to what we've gone through and what's ahead of us. So let's celebrate it together.
Yeah. Yeah. Fun, fun, fun. Where can people find you if they want to learn about these events that are coming up?
Oh, well, our website is harmony with an I dash wellness.com. We're on Facebook as Harmony with an I dash wellness. And then
No,
there's
no
an
dash.
MN at the end. Oh, there's no dash. Harmony Wellness and
MN.
for Minnesota. We're on Instagram.
Same handle.
Mhm.
Yeah.
Okay.
Yeah. So then so we promote it quite a lot. And then on our events page is usually where we can put some events. And then we also have a media page that has interviews that we've done, podcasts and things like that if people are looking for more information. And then our resource page has all of those vetted and recommended resources locally and nationally for more information.
Awesome. And I will include all of those in the show notes so people don't have to write those down or worry about whether there was a dash or not in there. They can just click that link right from the show notes. Of course. I always do that. Make things easy because a lot of times people are listening while they're driving, and don't write things down when you're driving. Just click on the link when you're done listening. And then any last words of wisdom you guys want to share as we wrap up today?
Oh gosh.
I appreciate you having us on. I mean, this is really something that is the movement forward, is all of us collaborating and supporting and learning from each other. Women's health just needs to be approached that way, as we are complicated and wonderful beings, and bringing in as many collaborators as possible to just support women to get to that optimal moment, what is ever optimal for them, is a gift. So I appreciate you having us on.
Oh, of course.
I don't have anything to add to that.
Okay. I was gonna say, you looked like you wanted to say something, Andrea. Awesome. Well, I appreciate you both so much for being here today. I love expanding our conversations and thinking about how our brains affect other parts of our bodies, because it's not just a brain, it's not just a uterus. We're all connected. Just think of it all as just one big happy body, right? So we need to make it happy by giving it the attention that it needs. So thank you for giving that attention and bringing that to my listeners today.
Thank you.
Thank you for having us. Our pleasure.
Course. Thank you so much. Have a good rest of your day.
Thank you. You too.
Bye-bye.
Thanks for tuning in to this episode of Brain Wellness, the podcast. If you enjoyed this episode, I encourage you to subscribe, like, and share this with others to help me continue on with my mission to help people live healthier, happier lives. Go to www.brainwellnesssolutions.com to see what I'm up to and get links to all the social medias there. See you next time.